Welcome to Radiographic Positioning Anatomy 2. This is your first lecture on image analysis of the lower extremity. The projections that we will cover this module is the toes, the feet, and the calcaneus. So specifically with the toes, the essential views are the AP axial projection, the AP oblique projection, the lateral projection, both medial-lateral and lateral-medial. And with the feet, we have an AP axial projection, an AP oblique projection, and a lateral projection, both medial and lateral projections. The calcaneus has two, the axial projection and the lateral projection. So starting off with the AP axial projection of the toe, this will include the digits 1 through 5, or you can collimate down to just the digit of interest and indicate which digit that is, whether it's 2, 3, 4, whichever digit. However, the anatomy of number 1 is similar to that of the thumb, where there's only 2 phalanges, the distal and the proximal phalanx, whereas the anatomy for 2 through 5, there's 3, the distal, middle, and proximal phalanx. To ensure that there is no rotation, you can look at each phalanx and see the equal concavity on either side. That indicates that there is no rotation. The joint spaces should be open unless the patient has curled toes. You do want to try to straighten them out if you can, but some toes are extremely curled. For this analysis, we're looking at an AP axial toe, and looking at the analysis, we can see that we do not have equal concavity on either side of the proximal phalanx of the first digit here. And this indicates that there is rotation. And for this particular rotation, the patient's foot was rotated medially because there's more concavity on this lateral side, or more towards the anterior surface of the foot, or the plantar surface of the foot. The correction is that you want to laterally or externally rotate the foot until the plantar surface of the foot is flat against the image receptor. Moving on to the AP oblique toe. What you want to see on a radiograph are all the digits from the distal phalanges through the metatarsal phalangeal joints, and all of the interphalangeal joints should be open if the patient's toes are able, unless they're curled, or you want to see the anatomy of the one digit that you've collimated down to. You will have increased concavity on one side of the phalange, each phalanx. You can see there's increased concavity, and the head of the metacarpals should not be overlapping. If they do overlap, that means that there's too much rotation. So looking at this oblique toe, we can look and evaluate for this first digit with the soft tissue width on both sides. We have nearly equal concavity and equal soft tissue on either side of the phalanx. This toe was not rotated enough in a 45-degree rotation. So in order to correct this, you would increase the rotation medially to a 45-degree rotation of the metatarsal phalangeal joints and the IP joint. For the lateral toe, the toe of interest should be separated from the other toes, as seen in this radiograph of the first digit, and this radiograph I'm going to assume it's the second digit. The digits are presented in the lateral position similar to your fingers. You want to see the condyle of the phalanx superimposed. Joint spaces open from the interphalangeal joint to the metatarsal phalangeal joint. We have the distal interphalangeal joint, the proximal interphalangeal joint, and the metatarsal phalangeal joint. You can see a small amount. However, the most of the anatomy of interest is the digit itself. and try to pull the toe away from its little pals of the other toes. The lateral toe. So looking at this lateral toe, this is the second digit, or the first digit again. And we have the distal phalanx, the proximal phalanx, and there is superimposition of the other digits with the first. So the first digit was not pulled away from the other, from 2 through 5, or the 2 through 5 were not curled away enough. So you're going to either use some tape or a tongue depressor or gauze, some type of immobilization device to move the other toes and curl them away from the anatomy of interest. Here's another lateral toe. This looks more like a AP, kind of like a oblique, not enough rotation. We do not have the superimposition of the condyles, and the joint spaces aren't open or have the greater concavity on the plantar surface of the phalanx. So you're going to increase your rotation to a true lateral. All right, for the AP axial foot, this is how the patient is positioned with their plantar surface of their foot flat on the image receptor, angling about 10 degrees cephalically, and opening up the joint spaces of the metatarsal phalangeal joint as well as the interphalangeal joints. You do not want to see any overlapping of the heads of the metatarsals, but you will have superimposition of the bases of the second through the fifth. All right, looking at this image, an AP axial foot, the joint spaces between the medial and the intermediate cuneiform is closed. So that is over here. The navicular tuberosity is demonstrated in profile. We see that here. The less than 3/4 of an inch of the calcaneus is demonstrated. We do not see that. And more pressure was placed on the patient's lateral plantar surface than on the medial. This resulted in a lateral rotation. You want to see open joint spaces. So we'll go back to the previous image. So we see the joint space of the medial cuneiform and the intermediate cuneiform. Here we do not have that open joint space. So the rotation towards the outer portion of the foot occurred. So you want to place equal amount of pressure along the entire foot and include the posterior or the hind foot as much as you possibly can. The oblique foot. The patient will rotate their foot about 30 to 40 degrees, and you will see that the bases of 3 through 5 metatarsal bases will open. You will see the sinus tarsi, the lateral tarsal medial joints, and the intertarsal joints will be open. You see right here the cuboid and the calcaneus and the navicular are visible. So this oblique foot, we can zoom in and look at the base of the 5th, 4th, and 3rd metatarsal, as well as the articulation of the cuboid with the cuneiform. The patient's foot was not medially rotated enough. We do not see the sinus tarsi either. So you want to increase the rotation medially in order to separate the bases of 3, 4, 5 of the metatarsals away from each other, open up the joint space of the cuboid from the cuneiform, and open the sinus tarsi. For the lateral foot, the metatarsals are going to be seen nearly superimposed, similar to a lateral hand. You're going to see the distal leg. The fibula, which is outlined right here, will be seen in the posterior half of the tibia. If you bring a line straight down through the tibia, the fibula will be located in the posterior half. And the tibio-talar joint space should be open. Now we do have different positioning errors that do occur. We will look at which direction the fibula moves. Now if the patient's heel was elevated from a true lateral, the fibula will be seen more posterior to the tibia. Now, if the heel was depressed towards the image receptor, you will see the fibula moving anterior to the tibia. The axial calcaneus, the patient is positioned with their leg fully extended with the foot hyperflexed until the plantar surface of the foot is perpendicular to the image receptor. We will also angle 45 degrees towards the head cephalically. There is another position for the axial calcaneus. I recommend reviewing that in your textbook. But for evaluation of, regardless of it, if you are doing a plantar dorsal projection or a dorsal plantar projection, what you want to see is the anterior portion of the calcaneus, including the talocalcaneal joint. Here in this example, the joint space is underexposed slightly. We can see a slight outline. We can do a second exposure by increasing our KVP by like 3 to 5 in order to penetrate that joint space, and keeping this initial exposure for the tuberosity or the posterior portion of the calcaneus. And we can see our sustentaculum tali in profile as well. Pay close attention to the flexion or extension of the patient's foot when positioning for an axial calcaneus. This image demonstrates what it would look like if the patient lets their foot relax and extends their foot rather than flexing. This image here demonstrates what it would look like if the patient overflexes, hyperextends, or hyperflexes their foot. It will actually close off the joint space. This is the perfect position foot. We're fully flexing the foot to a 90-degree angle and perpendicular to the image receptor. For this image, we can see the 5th and the 4th metatarsal laterally on this radiograph. This actually indicates that the patient's foot was actually laterally rotated or externally rotated towards the lateral side. In order to fix this image, what you would do is go back and rotate the foot until the plantar surface is perpendicular to the image receptor. We can see the posterior portion as well as the anterior portion of the calcaneus and the joint space. The lateral calcaneus is positioned similar to the lateral foot, and we can actually use the same positioning and anatomical parts to evaluate if it's a true lateral. So looking at the fibula in the posterior half of the tibia, the talar domes are superimposed and the talocalcaneal joint is open, as well as the soft tissue. We do need all the adjacent tarsal bones to the calcaneus. So that would be the talus, the navicular, and the cuboid must be present. So for this image, we can look at the fibula. Right here is an outline of the fibula. It is towards the anterior half of the tibia. This means that the heel was depressed towards the image receptor, or we can say that the leg was internally rotated from a true lateral. So in order to correct this image, to get the fibula in the correct position for a lateral, you will externally rotate the leg to a true lateral position. And if you want to look up more information regarding the content of this presentation, I recommend your Bontrager's handbook or textbook in positioning. Also, the Long, Frank, and Smith, the Merrill's Atlas for Radiographic Positioning and Procedures, found in the library, and then also your textbook on image analysis, Martinson, is the sources that I used to create this presentation.